Good morning or afternoon, depending on where y'all are in the country. Thank you very much for taking some time out of the unprecedented things that are happening not only nationally, but certainly in your local communities. And special thanks to the presenters for this WebEx and webinar to help us understand the myth versus reality from something that was rather unique in their community. This all came about last week when Jimmy Pierson shared with me what he and his team and the folks that you're going to hear from here on this webinar went through at the ground level, and it was an amazing story, and we felt that it would be exceptionally valuable for Jimmy to share with and his team, the folks there from the county and the rest of the team, what they learned, what they are currently experiencing, and really give the country the opportunity to ask them some questions about what they're doing, what they did, some of the experiences that they had. We are exceptionally blessed to have FirstWatch and Todd Stout and his team to host and coordinate this event. We had over 1,200 registrants, typically, or in addition, I should say, to about 300 people who are joining us from Canada at the invitation of Kevin Smith from the Niagara Region EMS as part of their emergency management conference. So everybody from Canada at the conference waves so we can all see you. Thank you for doing that. That's really awesome. Todd, again, thank you for hosting. Do you want to walk people through how they might put questions into the queue? The presenters, so that you all know, are planning about 30, 35, 40 minutes of content to give enough time at the end to answer as many questions as possible in the hour that we have. So, Todd, take it away.
Great, thank you. Everybody should see a how to ask questions screen. This information will be presented right at the end of the normal conversation as we start questions, but we thought it would make sense to make it available for you, so as you think of questions during the presentation, you can go ahead and type them in. Do us a really big favor, and in the chat window, select to send your question or comment or thought to host, presenter, and panelists. That way, all of us will see your questions, and it will make it easier to make sure we get you handled. You'll then type your question or message into the little window beneath the Send To area and hit Enter. In some browsers and operating systems, you might have a Send button that you click as you go through that. But go through that. We'll watch for those, and we really appreciate it. Again, we'll show you this session again. I do also want to mention, for those of you that are used to our webinars, this is our 5th COVID webinar, for example. Some of the features are a little different because with this many attendees registered, in order to maintain the system and it sort of at its best, some of the things are not available. So if it looks a little different, that's probably why. We're lucky to have Robbie from Cisco on with us to help us manage any problems and issues that come in, and we're super excited to be able to present this. So again, I'll show you this how to ask questions later, but feel free to type in the chat window throughout, and we'll try to get to you at the end. Thank you.
All right, thanks, Todd. And again, great collaboration on this particular webinar. A number of organizations were part of this, helping to promote it, get the folks together. So great international group, local, national dispatch agencies, et cetera. And again, Todd, we can go to the next slide. And just want to, again, thank you for hosting it. We have 3 people that we'd like to have introduce themselves to you briefly and explain a little bit about their role every day. And then we'll get later on in the webinar what their roles were during this actual event that they're going to tell you about. So, Jimmy, you want to start?
Yeah, thanks, Matt and Todd. Jimmy Pierson, President and COO of Medic Ambulance Service. We're the 911 EMS provider for Solano County in California, Northern California, population about 430,000 people. We're an exclusive operator and been in business since 1979, have over 300 employees, and run about 56,000 calls per year.
All right, thanks, Jimmy. Dr. Matyas?
Yeah, hi, this is Bela Matyas. I'm the health officer for Solano County, so I run the public health programs countywide.
Okay, and last but not least, Ted.
Good morning and afternoon. This is Ted Selby. I'm the Emergency Medical Services Administrator for Solano County, and I have the privilege of working with Medic Ambulance and overseeing all the great work that they do. as well as coordinating specialty care programs at our healthcare partners' facilities within the county.
And Ted, knowing Jimmy, we know that's no small project, so thank you for overseeing Jimmy. We know that can be challenging at times, so no problem at all. All right, let's go to our first question for the panelists. First, give us an overview of what happened. Jimmy, why don't we start with you? Here are some images that you sent us from what was going on at the time. Dr. Matyas sent these, a couple of these as well. But just give the participants an overview of what happened.
Yeah, so I'll let Ted start that and then pass to me, just because Ted was the first person to get the what happened, and then I'll kind of take how I got it from there. Is that good, Ted?
That works for me. Hey, so this is Ted, the EMS administrator for the county. I received a phone call from our Health and Human Services Agency Assistant Secretary for Preparedness and Response Project Officer in early February, telling me, hey, Ted, I know I don't talk to you often, but we've got some activity coming up at Travis Air Force Base in your county and wanted you to be aware of it. And I said, well, what exactly are we talking about? And he said, and he kind of laughed and said, you know, we're talking about repatriation of U.S. citizens from abroad, from China. And I said, oh, okay, and what exactly is it that you need our assistance with? This is a federal mission, right? And he said, well, yes, it is, but, you know, the Department of Defense isn't going to be playing any part in the healthcare or medical aspects associated with this mission because they're not military personnel that are being repatriated. So that was kind of how it started for me, and then I started communicating with members within the Public Health Department and our Office of Emergency Services, as well as and the state of California, the State Department of Public Health and the Emergency Medical Services Authority, and then reached out to Medic Ambulance, my friend Jimmy, as soon as I heard, and that's when we started talking about some strategies to address the potential influx of folks that might need assistance.
Yeah, and this is Jimmy now. And so for us, this is about 5 weeks ago now. This isn't, I know everybody's kind of fresh on it in the last 2 weeks, but we got started dealing with this about 5 weeks ago. So how to treat corona patients, what that entailed. The nice thing about having many federal agencies, a part of this is that the CDC was on site, so we were able to have conversations directly with them on what the proper PPE would be. We also were told that we didn't expect any corona patients, that these were all quarantine patients, but because it's a 10-hour flight and some were of age, that they may need to be transported. So during that process, we had 2 airplanes that came in, and we were just dealing with quarantine patients that were what's defined as persons under investigation. So they may have had a fever, but no one was positive corona in the first 2 planes. And then the Diamond Princess happened, where they bused everybody from the Diamond Princess to the plane, and in multiple buses, in multiple hour length bus transports, got everybody on the plane. Then as everybody was on the plane, they were told there were 8 people on the plane were positive with corona. Or with COVID-19. And that was passed along to us. They were leaving, so now we knew that there was 8 corona patients or 8 COVID-19 patients coming to Travis. And as Ted said, the DOD, for protection of our military, which makes sense, these patients needed to be transported to local hospitals. And that's what triggered our mass casualty response. Ted, Bela, the communication with all our local hospitals and how to properly allocate these patients. Because Solano County is 450,000 people. We have 5 hospitals. They're not very, very large hospitals, but we're closer to the Bay Area, Sacramento, so coordinating with the region. And that's kind of how that's how this happened and how we were dealt with it, with that answer.
Yeah, excellent. So, Doc, at what point did you get notified, and what were some of your first thoughts when this process started to unfold?
Well, I was actually notified by Ted when he heard about that first plane load or pair of plane loads of individuals that were going to be coming out. And, you know, we weren't the first location to receive repatriated State Department employees. That was Riverside County and the March Air Force Base, March Air Reserve Base. And so when we heard that there would be additional plane loads coming out to Travis, we had the opportunity to talk with the folks down there and try to identify what they had learned, lessons learned, what kinds of things to look out for, et cetera. And we were actually able to utilize a lot of that knowledge to be better prepared for the evacuees who arrived here at Travis Air Force Base in Solano. In total, there have been 3 waves of evacuees to Travis. The first wave involved 2 plane loads of individuals who were State Department evacuees from Wuhan, China. The second wave, the third plane, involved individuals who, as Jimmy said, were evacuees from the Diamond Princess, which was basically a floating petri dish off the coast of Japan. And then most recently, the Grand Princess cruise ship that docked in Oakland has resulted in the transfer of 950-plus individuals to Travis as well. So this is, we've pretty much been doing this constantly for the past month and a half. What we were able to do with Jimmy and Ted's assistance is make sure that the county could properly handle those evacuees coming from Wuhan and then subsequently the Diamond Princess who were in need of coming off of the quarantine site at Travis. So one of the problems that occurred, but again, it's totally understandable, is that the quarantine site at Travis was only to quarantine people. And if anybody became symptomatic, became a PUI, or if anyone was identified as having coronavirus through screening testing, that they had to leave that quarantine site and come into the community for care. And so we were very fortunate, as Jimmy said, in the first 2 plane loads, the State Department evacuees, there were only 5 PUIs, none of whom ended up having coronavirus. So we did have the opportunity to use the MCI process to transfer those to local hospitals. The hospitals held them in isolation, did the proper evaluation, and they were all able to go back to Travis to finish off their quarantine. That third plane load, the second wave, the one from the Diamond Princess, was altogether very different. We knew when they were coming that there was going to be a lot more likelihood of illness occurring among them because they had been on board that vessel where at that time, there had already been reported over 500 cases of illness and multiple deaths. So what became typical of the sort of the communication reality was the lack of clear and timely knowledge about what's going on. As Jimmy indicated, the initial promise had been that nobody was coming to Travis that was symptomatic or was at risk of illness. But then we learned when the plane's halfway here that there are actually 8 people on board who are coronavirus positive based on screening from Japan. And then what emerged over the subsequent 2 to 3 weeks of that group's stay at Travis was that more and more people were found to be positive based on Japanese testing. CDC decided to test everyone at that Travis quarantine site, and many more were found to be positive. And then on top of that, we had the load of PUIs, so that from that one evacuee group, we had about 30 individuals that needed to be transported, either because they were positive for coronavirus or they were actually showing symptoms that required evaluation. So what had been an easier, more steady stream of movement of individuals off base with the first 2 plane loads became a much more sort of steady flow and higher volume with that second set of evacuees. And it forced us to learn new lessons and to come up with other ways to deal with the process of making sure their needs were met.
Hey, Bela, wow. This is Ted. I would be remiss not to mention here what great leadership capability and skills you have. Because during that time frame that you were describing with the Diamond Princess, and all of the folks that were testing positive from not only the Japanese results that we received, but also from the testing that was done by the CDC on site, we had that first community transmission within our county. And at the helm, you were able to handle both concurrently from that health officer perspective and that leadership that you demonstrated. And I don't know if you can maybe speak to what happened, how difficult it might have been, the community transmission, and at the same time having all of these difficulties with these positive returns coming from the repatriates on base.
Thank you. Obviously, the only reason I'm any good is because we've got great staff here in the county. I think that one of the most important things to recognize is in all of our jurisdictions is that we're going to have to rely on the people that we have to deal with this type of situation. Even though it's a federal mission, the people who spill out of the base become county responsibility. And then probably most of you by now are experiencing issues with coronavirus in your own communities, totally unrelated to evacuees per se. And we all have to sort of assess the ability to handle these sorts of things, and then to make that transition from the concept of containment to the concept of mitigation. Solano I thought we had the benefit of having dealt with the evacuees as a way to prepare us for dealing with what was inevitably going to be community transmission, so that it was an easier transition. I think we'll talk more about this in the questions on lessons learned, but what we were able to rely on was the strength of our healthcare system and our EMS system. It allowed us to make sure people were moving off and on the base, or off and back to the base as appropriate, between hospitals as appropriate, while at the same time handling the outbreak in the community.
Excellent, excellent. Let's move. I want to move to the third question, Todd, if you can, about the aha moment. So we heard a lot about what happened and what some of the roles of the presenters were. But for each of your perspectives, when you think back, or as this now continues, right, so you're learning literally as we go, what were a couple of those aha moments each of you had during the event that you thought, gosh, I wish I had known that ahead of time, or something like that?
This is Jimmy. I'll go first. One of our biggest aha moments for us was employee communication. When the first ones came through, they weren't they weren't COVID-19 patients. So, but there was the training and aspect, and then once we had the community spread call out of a local hospital, and a couple of our employees got put on quarantine, and we had what was going on at the base. We were relying a lot on our normal internal communication through paging, blast emails, but we realized that things were getting lost in translation, and that we needed to go face-to-face immediately. So all our supervisors, our leadership team met every morning on a conference call so that everybody, field soups, directors, managers, were all on the same page, that there wasn't any misinformation, because as you see currently in just different media outlets and how things can go, and I think that's streamlining a little bit, but we have sometimes bad information, and 2 weeks ago there was even worse information out there, and employees' families and how they have young children at home, or they live with their family and their parents have comorbidities and just all these things that they didn't want coming in their home. So there had to be a lot of education. So that was number one. And, relying on our successes so far, we are not the CDC. We're an ambulance company, right? We're learning how to properly use PPE and make sure it's being done correctly, and educating on that, reinforcing our stats to date. And at that point, we had transported 20 COVID-19 patients and multiple PUIs, I think another 20-plus PUIs, and none of our employees were symptomatic, sick, or on quarantine, that everything was working as it should, and that we were in direct contact with TED, Bela, the CDC, luckily to have those resources locally. So employee communication was immediately our biggest aha right away, what we needed to fix and change. Ted?
So thank you, Jimmy, and aha, that was very good. Communication is absolutely the key to success. I mean, there's no question in my mind. One of the aha moments for me was in the planning for both the returns of individuals coming from abroad, as well as Grand Princess folks that were coming to Travis. It's so important to ensure that you have all the key decision makers on your planning calls. One of the lessons, and it's not really a lesson learned, I won't go there, but it is a lesson learned, to ensure you don't overlook anybody, and particularly those members of executive leadership. Make sure that they have the information, and if they're not in your county, but they're part of your process, you want to make sure that they're aware that these planning calls are going on. We did have some interesting conversations and discussions where representatives of different organizations may have made commitments on behalf of organizations, and then come to find out those weren't communicated up their chain of command. So to try to ahead of time ensure that everybody is in the loop. And I know it's hard to do, and people get overlooked, but if I could, just emphasize one point, don't leave anybody out. Do everything you can to try to make sure that the people who are doing the work, as well as those executives, are all on the line so that everybody hears the same message and understands the mission. One of the other ahas was that utilizing, in California, I know we have people dialed in from other areas. In California, we have the standardized emergency management system that was put into place back in the mid 90s after the Oakland Hills fires and Loma Prieta. And it's very effective for emergency management, but it's different than a lot of other areas. And then, so we follow incident command. And within Solano County, we have a multi-casualty incident plan within the EMS agency that we utilize that uses a hospital network that some of those hospitals fall outside of our geographic region. So the aha is to make sure that you keep the other region informed. If you're going outside of your normal or your general emergency geographic region, make sure that you incorporate communication and advisements into the neighboring jurisdictions. It's just, these are ahas that we maybe don't think about, because on a daily basis when we have multi-casualty incidents, that's not a necessary step. But when you have these high-profile missions going on, everybody needs to know. So I'll pass it along to Bela after that.
I think Ted's point about over-communication is really important. Our over-communication has been very, very beneficial in keeping people in the loop on what's going on. For a long time, we were having phone calls that we set up for our county providers, EMS and hospitals, so that we could keep them informed about what was going on with the evacuee situation. And after a couple of weeks, we came to learn that there were literally hundreds of people on those calls from all over the region, because they were not getting comparable access to information. And so it was really clear that people were very much wanting to have a better idea of what's going on. And I think over-communication has proven to be very, very beneficial, although obviously very burdensome. I don't think a day goes by when I'm not on 6 or 7 conference calls for the last several weeks, but that communication is extremely important. So I have, I guess, 3 pseudo-aha moments. One's really a bummer, the other's a thank God, and the third one is why am I not surprised. The bummer is my impression of what's been going on in this particular situation is that the federal level just doesn't seem to learn from the past. It says this coronavirus outbreak has been handled as though there had not been previous pandemics that we've been able to do well with and learn from, and so many mistakes are being made that are completely avoidable. And related to that is the conflicting CDC missions of providing the service, for example, for these evacuees at the ground level at Travis, with their desire for science. And their science has made the practical mission impossible to do well. And by that, what I mean is the insistence on the part of CDC to screen everyone at Travis without fail meant that we had to identify a couple of dozen people who were asymptomatic but nonetheless shedding coronavirus. And that forced our hospitals to become hotels using their isolation rooms for people that had no place being in a hospital but who could not be released because the federal quarantine refused to let them be released until they had 2 negatives to clear. And that has proven to be an extraordinary burden on the hospitals that had to sustain that. And no matter how much we screamed with the folks at CDC about how inappropriate and impractical that was, they just didn't seem to care. The thank God is that we have Medic and we have great hospitals. And I'm not going to pretend that Medic is not an extraordinary EMS provider. I think they are, they are above all. I mean, they have no parallel. They're so good. And that's not to make Jimmy feel good. That's just the reality of it. I mean, they are an extraordinary EMS provider. But, with them, with our hospitals, with TED's EMS oversight, our policies and procedures that were in place worked. We didn't need to create new stuff. We just needed to implement what was already in place. And when it was followed, it worked extremely well. And the only times that it didn't work was when the feds got in the way of a normal process that worked well. We were able to move several dozen people around the region as needed off base to provide the services that they required. And I think, the lesson in that is if you've got a good baseline approach for dealing with MCI, use it, because that is going to work in this situation. And then the why am I not surprised is that the information out there from the people we're supposed to trust, the World Health Organization, the feds, the state, they're far too purist in their approach. And as a result, a lot of what's out there is simply impractical at the local level. And we've had to deviate from almost all of it just to be able to make things work at the ground level. And sadly, so much of what is being put out there is just not accurate, even by the people we're supposed to be able to trust. Things like the death rate of the disease and, the degree to which asymptomatic shedding is important for transmission. I mean, these are things that are actually creating a lot of concern and panic in communities that is completely unnecessary.
Wow. Excellent insights. Thank you very much. Jimmy, I want to go back to you for a second. And the doc mentioned it. From a practical perspective, how did you guys use PPE? What was the PPE? You had mentioned earlier in a conversation that a couple of your folks needed to be quarantined. What did that really look like? And what were some of the other considerations that you had to take into account to be able to get employees able to report for work and put ambulances in front of addresses?
Well, I got it. That's an easy one. The PPE, and I've seen some questions too, is really right off the CDC and working with them. It's N95 masks, eye protection, goggles. We would also use a face shield as well, a gown, boot protection, and hair protection. And that's it. It's not the Tyvek suits. It's not the PAPRs. Medic is, in the state of California, we have regions through OES. And we're one of the region 2, which is where we're at, highly infectious disease, so Ebola-type patients, authorized transport providers. So we have the isopods, we have the Tyvek suits, we have the PAPRs. The CDC was very clear in the beginning that is not needed here. Now, one of the big issues we had, too, was there was a couple other areas within the country when patients arrived there, we had other services in full Tyvek suits, PAPRs with isopods. And our employees would say, whoa, are we not? And the nice thing about having the feds right here is we were able to talk to them directly, and they reassured us and our local public health that we're doing it. This is how it is. And you don't need to Ebola the rig, have you seen? You don't need to do all that. You need the proper disinfectant tools. You need to give the confidence to your crews, right, that this is how it's being done, and this is how it needs to be done. And also to be smart about it, right? If you don't need to neb somebody, don't be a neb. We talked to, when Travis came, we knew this was coming. We had direct conversations with our medical director for the county, Brent Mumma, and our medical director, Paul Keevala, and the questions were, if we don't need to do it, let's not do it. So let's just essentially stop it. And we haven't had sick coronavirus patients yet, except for the one, and that kind of moves into the next, was the community spread patient that went from one of our local hospitals to a regional hospital that North Bay was treating for viral. One of our crew members was wearing an N95 mask. The nurse was not. and neither was the additional nurse because it was a CCT call. However, the patient was on a HEPA filter, and all other precautions were taken with the patient. And they found out at UC Davis that the patient was positive for COVID-19. So that crew, that EMT and nurse, were put on 7-day quarantine because it was 7 days into when that happened. They actually luckily had not worked, and they were put in quarantine. This also brought up that aha about communicating and talking to our employees about family and how it reacted, because the EMT that was put on quarantine's family did not want her to come home. So we had to coordinate with local health officials on where to put that patient, and we were able to find a common place, the patient, for that employee, put that employee where they could live in quarantine for 7 days. So there's a lot of things that go into, this aspect with the home life and the employees. And we've had 4 ambulances at Travis. We had 4 ambulances at Travis for 17 days, 24/7, that were dedicated to the quarantine patients. And now that we have the new cruise ship that just came in 5 days ago, now we have another 16 to 17-day mission at Travis again. Again, it was not, we actually have all those 4 ambulances fully staffed pretty much for the 17 days because of how we communicated and explained to the employees, and they saw firsthand that we're not putting them in harm's way, and that the PPE that's being requested and that they have on site is what they need to do to treat these patients. So I think communicating, having the right equipment, understanding the CDC regulations, being in direct contact with your community, people like Ted, like Bela, getting that support is what makes us successful, as, knock on wood, has made it successful to this point.
Thanks, Jimmy. As we go into the, I'm sorry, someone else wanted to comment?
I did want to add a couple of things. I mean, a couple of pragmatic decisions we've had to make here. One with regard to dispatch. Originally, we were providing them with the locations of people known to be positive or under quarantine so they could take proper precaution upon arrival. But that's become untenable because there are just so many people now in our community that fall into that category that we've actually gone to a universal query before arrival for anybody who has respiratory symptoms or fever, and then wear CDC appropriate protective equipment when you dispatch to a location that has that. And then the other is, in order to maintain functionality of EMS and other first responders, we're no longer quarantining potentially exposed individuals at home or allowing them to continue work as long as they do pre and mid shift monitoring for signs and symptoms, and then if they become positive for anything, then at that point that they're isolated and removed from that workforce. But we've needed to make those decisions in order to preserve our workforces.
Excellent point. Excellent point. Thank you, Bela. Last question, and we'll be brief so we can get to some of the questions that folks are sending in. So you've had this experience, it's ongoing. If you could give one piece of advice to local communities who are dialed in and who are going to be listening to this to help manage these patients and manage situations, what would that advice be? And we'll just go around the room and ask folks.
This is Jimmy. I'll start again. Kind of twofold is educate your staff, communicate with staff, make sure you've ordered all the PPE you need. And then secondly, MCI programs or policies, bed allocation sounds really good until you tell hospitals in your community that you have a COVID-19 patient. And then I can't say enough how impressed I am with our local hospitals. And we've had a lot of regional support, but there are a lot of hospitals in our region that just shut down, that had beds the night before. And once we put 8 COVID-19 patients in the different hospitals, there was no more beds available in the Bay Area with, 4 million plus people in multiple hospitals. So I will say that work on your contingency plans, know your bed isolations, and make sure that the communication pathway down to your employees and staff, and also up to your TEDs and your Belas for your communities, and make sure everybody there is on the same page, and be ready for people to not want to take patients. Go ahead, Ted.
So I'm gonna piggyback on Jimmy's comments a little bit, because I agree with him. What we found initially with the first cohort of repatriates that came was that the multi-casualty incidents plan that we have worked quite well because we had a pretty healthy cohort of individuals. I mean, it was a broad cross-sector of ages and the demographics, and so there weren't a lot of sick people, and really they came for their quarantine, and the few people that we did transport, we were able to handle within our own system, which brings to mind a quote by Teddy Roosevelt, who said, "Do what you can with what you have where you are." That's what you do every day. That's what you're familiar with. That's where you'll be successful. Rely on those plans. It's once you move into the regional response, as Jimmy was mentioning, he's absolutely right. And so the advice would be to try, if you anticipate an influx of people, not just community-acquired COVID-19, but an influx of people coming, I would highly recommend that you work with whatever regional personnel you have to communicate with the hospitals, because that is, I mean, do what you're familiar with first. If you have to go beyond that, communicate, and I'll pass it along with that.
All right, Bela?
I think that probably the best advice I can give for both EMS and for healthcare is rather than expecting to have perfect knowledge about who you're interacting with, knowing that a person is or may have coronavirus, for example, we have found it necessary, and I would recommend you pretty much just start with universal protection using empirical indicators, because you're not going to have anything else that you can rely on real time. So, you want to identify people who have symptoms consistent with this, so fever, cough, shortness of breath, and assume, knowing full well that not all of them have coronavirus, assume that they all have it, and use droplet and contact precautions in transport and in healthcare provision for those individuals. Take that approach universally, droplet and contact, and recognize that really the only practical way you're going to know who you're dealing with is by the empirical evidence of symptoms. Now, that's not a purist's approach, because there's no guarantee that we don't interact with people who don't have those symptoms who are nonetheless able to transmit. But there is no other pragmatic way to address this issue at this point. I mean, the disease is widespread. It's in our communities. That's not going to change. And we have to weather this first wave of impact in all of our communities. And I think what you need to have are rules of operation that are easily implemented.
Excellent. All right, Todd, we're going to go to a couple of quick questions, if you don't mind, and one that was sent in relatively early and was pretty pragmatic. Decon. So, Jimmy, the rest of the team, Decon, how did you do it? Did you have to do it? What did it look like?
It's detailed, but it's with, the Cavicide spray, the Clorox wipes, making sure you're cleaning every surface. I will give Richmond Ambulance Authority a shout out. Before this even right when it was slowly hitting in Wuhan, they had something they put out on using Duran, DC Medical's biochemical cleaner and their gun machine, and then also testing samples inside the rigs and how to do that. And so we had learned from that probably about a couple weeks before, and we're doing that on our logistical side. But these post calls, your regular Cavicide spray, Clorox wipes, making sure your crews are deconning the entire patient compartment after every call is good enough, and then letting it, rest and be clean. But also, I will say, expose your entire cleaning process on regular calls, right? This isn't just, no matter even if it's COVID-19, this should be an eye-opener for EMS in general. And is your agency properly cleaning the front of the cab, the back of the cab? And I just want to give kudos to Richmond Ambulance Authority, because I love what they're doing, and we totally replicated it and stole it.
All right, thank you very much. And we're going to do a couple more questions, but Todd, do you want to talk about the next webinar, because it might go into some more details about some of those questions?
Great, thank you very much. I definitely appreciate it. So as I mentioned at the beginning of the webinar, for folks that were here, I know a lot of people joined partway through. This is actually the fourth in a series of COVID-19 webinars that we help Paramedic Chiefs of Canada and the International Academies of Emergency Dispatch. This is a broader, more joint webinar that we're on today, but on March 26th at 10:30 a.m. Pacific, we'll have lessons learned from first responder and paramedic quarantine. Jimmy, because he's had a couple of staff quarantine, will be there. We've invited Kirkland Fire, who's had a fire station and shift quarantined in Washington State, and then we've also invited folks from Toronto paramedics who during SARS had over 50% of their 850 paramedic staff quarantined at home at one time. So I think that could be one of the larger challenges we have. We've addressed a couple of it today, but encourage you to go through there. An email invitation will be sent out to everybody who's registered for this webinar. Additionally, you can sign up for notifications by going to our Health Intelligence page at firstwatch.net/HI. That is public safety specific take on this kind of stuff. We've been doing it since H1N1, and as Dr. Matyas pointed out, the official advice and recommendations aren't always practical and often are not geared towards 911 and EMS, and so we invest a lot of time and energy and make it freely available to try to translate that down. We have a paramedic nurse firefighter, Pam Farber, who's amazing at that and really puts all that together. And I would encourage you to sign up for Health Intelligence updates. You'll get those notification of the webinars as well. Also, for those of you who are wondering, this recording will be sent out to everybody. A PDF of the PowerPoint will be sent out to everybody. So please, feel free to follow back up anytime that you need. I'll just tell everybody who joined late, here's how you ask questions. You use the chat window. There is a Q&A feature. We're not using that as much. I will check it, but please, instead of the Q&A feature, please use the chat window. Send your question. Super important. Send it to host, presenter, and panelists so we all see it. Select send to host, presenter, and panelists. Type in your message and hit enter. In some browsers, you'll have to click send. Thank you very much.
Thanks, Todd. And one of the questions that came in through the chat is something that would directly tie to the workforce and the quarantine issue as well. And I think it, Bela, you may have mentioned it, that even though the EMS workers, healthcare workers were potentially treating someone with COVID-19, they weren't necessarily quarantined unless they were symptomatic. So can you clarify that for the audience a little bit? What really triggers the ability or the need for someone to go into quarantine?
Well, so, I mean, typically what would happen is that a person is exposed to an infectious condition like COVID-19, and then you put them in quarantine, in this case, for 2 weeks. Quarantine means that they don't have symptoms, but they're not allowed to work. So they're furloughed for 2 weeks while being monitored for symptoms. The impact of that is that very large numbers of people in the workforce end up not being available for the workforce. And only a small fraction, if any, are actually going to develop disease. So the alternate approach that we've taken, and frankly, it's an alternate approach that the CDC is moving toward based on their experience with us here during the investigation, is to permit people to continue working, but with very aggressive monitoring so that at the earliest onset of symptoms, they can, in fact, then be isolated and kept out until they resolve their symptoms. But the premise is that while they're working, they have to take proper precautions to avoid transmission to potential patients. So in the healthcare environment, for example, the people who are in theory on quarantine are actually under observation in the healthcare environment continuing to work, but they have to wear a mask with all their interactions with coworkers and patients, and they need to be tested pre and mid-shift for temperature and any other symptoms. And if they go through the 14 days, then everything's fine. If they become ill at any time during those 14 days of the quarantine monitoring period, then they are furloughed and they stay home pending resolution of symptoms.
Yeah, Bela, this is Jimmy. Just want to make a little clear there. That's if they treated an infectious disease patient without the proper PPE, correct?
Yes, that's for anybody who on the list of criteria, for those of you who aren't familiar with this, CDC has published 9 levels of risk for healthcare workers, and those that would be medium or high risk, that's the ones for whom this alternate approach pertains.
Excellent. And Jimmy, to that point, you saw one of the questions that came in was, again, a little bit of a clarification about the PPE and the type of mask that you guys are using to for contact with these patients.
Right now, we're using N95. The CDC did say that you can use just a regular fluid shield mask, but we have a good supply right now of N95 masks. We've educated our staff. We feel like they're using them on the right calls. They need to be using them, and N95 is what we're using. We do have an extra supply of N100 if we get down to it, but that's in a backup staff, and that's in another staff. But right now, we're at an N95 is what we've been using.
Okay, and one of the questions from the participants was plastic sheeting inside the ambulance. You touched on this a little bit, but could you reemphasize, are you doing anything specific for the ambulance, plastic sheeting, PAPRs, just clarifying for the questions that are coming in relating to that?
Yeah, great question. We're not doing like an Ebola sheeting. The units that we're using for these, we have type 1, majority type 1s. We do have some type 2s that we're using, type 2 ambulances. The CDC recommendation was to try and use type 1 for these patients because of the split cab. So in our type 1 and type 2 vehicles that we're using, we put the sheeting around from the crew compartment to the patient compartment just to protect that seal, but that's all we do. And then also we turn the exhaust on whenever the patient's in there, and we recommend to the front staff not to use circulated air or the air conditioner at all if they don't need to, which, you know, we've had good weather here. The AC is not needed, so don't circulate air if you don't need to. So the sheathing part that all we're using is sealing the front and back cabs.
Okay.
And then also just to clarify, too, with the patient, that I think is important, we put all those patients are on a mask as well. Some have even gowned up. And we put an emergency blanket over our gurney and sit the patient in the emergency blanket and then wrap them with either that emergency blanket or we add another emergency blanket to cocoon them, essentially. And that comes from even our HID system, the high infectious disease, is even looking at going that way without isopods. So just a thought, when people have those, cocooning the patients, and that also helps protect anything getting on your vehicles or, on your gurneys, or you still need to disinfect and clean all that, but that's just another layer of protection.
And Jimmy, are you using droplet precautions on the patient themselves?
Yes.
Okay. Question for the doctor. Are there any treatments currently available for COVID-19, or is it currently just you have to let it run its course?
There are clinical trials underway with some FDA-approved emergency use drugs that are being used on patients in hospitals. So hopefully within a few weeks at most, we'll have some data on whether those particular antivirals have any benefit. And if that's the case, then there will be guidance released immediately on treatment. But it will only be for treatment of hospitalized people. There isn't going to be any treatment for people who are able to remain at home with their symptoms.
Okay, excellent. And another question for you, sir. One of the participants wrote in and asked if there's a possibility that this corona or COVID-19 could mutate into a different type of virus that perhaps we're not as prepared for or maybe harder to treat.
Well, I think that's always true of any disease. It happens all the time, for example, when diseases that we currently know about develop antibiotic resistance. So all kinds of bacteria in our communities have become harder and harder to treat because of those types of mutations. So that is definitely a reality we always have to be willing to confront. So a modification of the current virus would potentially affect its ability to do harm and would potentially affect the ability to treat it, even if we come up with a treatment. Unfortunately, there's not going to be any way of knowing that except by continuing to observe it. And so if we come up with an effective treatment and then it stops being effective, that would be one indication that such a change may have occurred. But the question is valid insofar as nature does that all the time. That's why we get novel diseases happening all the time.
Okay, thank you. And Jimmy, one for you about quarantine for EMS personnel. if you had to quarantine them, let's say they're symptomatic and they had direct contact, where are they being quarantined? There's a question here about, can they take it home to their families? Where is that quarantining taking place? How are you facilitating that?
So if they're symptomatic, they're going to the hospital. If they're asymptomatic, which ours were, they're isolated at home. They ask, Bela might have the better answer exactly what the CDC recommendation is, but it's a separate room in their home. I know our employees, they got their house to themselves. Well, one of them did. The other one wouldn't let them come home. So we had to coordinate a room for them in their own area through the public health. We worked with them. So, they were put in their own areas and they had the house to themselves, and that's what we'd recommend. Preferably, like I said, talking to the employees and their family, have the family go with someone, live with another family member and let the employee stay at their home. But if that's not possible, it's just communicating, finding out what their home life is like. They may not be able to afford it. They may be in the middle of a divorce. I mean, there's so many different layers, and communication and understanding who those employees are. We, my regional director of operations, Brian Meter, made phone calls. I made phone calls to him. Brian called him every day. I checked in with them and made sure they were good, and that everything was checking in. So it's just, the location, though, is going to be a variable because of everybody's home life, and you just have to have that open communication with them.
Okay, makes sense. Another question's come in for clarification. EMS crew members not wearing PPE unless the patient is symptomatic, or is it, how are you making that determination of definitely got to wear PPE for this type of patient, maybe not this type of patient, et cetera?
So PUIs and any corona positive with symptomatic, no symptoms, get the full PPE we've been discussed. Currently, if we get a 911 call with flu-like symptoms or fever, we're telling everybody wear N95 and put the patient on a mask as well. And they have the option, if there's a lot of factors that they think, they can go to the full gown. But right now, we're just asking for the mask on the crew and the patient. And that's any respiratory, upper respiratory infection type call, flu-like symptoms, fever present type call. That's what the recommendation is here locally in Solano County with our staff.
Okay, thanks, Jimmy. Another question for the doc that just came in, and we've sort of not heard a lot about this, but two questions really. How long does the virus survive on a surface? And then the second part of that is, what about the virus being on clothes or other things that might go to patients or to the crew members' homes or other places they might go to in between their work site and home?
Those are excellent questions. It has to do with the concept of fomite transmission. And I think we know that the virus appears to be able to survive on some surfaces, possibly for a couple of days, based on the most recent information from CDC. What we don't know is whether anything that is on surfaces or on fomites is competent to actually transmit disease to someone else. So if we think about it from our knowledge of influenza and other respiratory diseases, it's almost a certainty that fomite transmission can occur, but the importance of it relative to direct droplet transmission is what is important to ask ourselves about. Again, if you take a purist approach, there are probably some people that spread by airborne, and fomites probably can transmit, and there's probably even fecal-oral transmission, but none of those compares to the importance in the intensity of the outbreak to droplet transmission. So if your goal is to have zero risk of exposure, then you need to practice universal precautions all the time. If your goal is to have pragmatic reduction of risk, then you want to practice droplet precautions when you're confronted with a person who has the appropriate symptoms. But I don't think we should be asking the question on the assumption that we can avoid bringing fomites home or having them on services, because it's being transmitted widespreadly in the community anyway. So exposure to it is going to be a high probability event no matter what we do in an individual situation. And that's an unfortunate reality of this disease. It is it has a high RO value. That means that it's able to spread from one person to others very well. And that's why it's been propagating around the world as it has. The only accompanying good news is that most people who are not elderly and otherwise have compromised health, that for people other than that the disease is generally asymptomatic or very mild and will pass without any complications.
Okay, great explanation. Jimmy, another question's come in, and maybe Ted from other systems that you may know. What type of call triaging is being done in the communication center, and how are the crews notified of some potential risks that they might be responding to for an infectious disease?
So we're an IAED ACE accredited center, so we're getting all the updates through card 36, I believe it is, and not all of we have 6 PSAPs, not all those PSAPs are following full EMD protocol. So the one issue we have as a local county is essentially we don't have the luxury of a centralized EMD dispatch center, so we all have to communicate with each other. I will say that our local PSAP, public safety answering points, and our dispatch centers have been communicating, and we have had multiple calls where that's being relayed to the crews of precaution. But I would say it's not as, in our region, it's not as clear, but if you have a consolidated dispatch region that's following IAED, they are on it, and they're giving great information back to us. And I saw me and Sandy, who's our VP of Communications, and also my sister, went through it all yesterday, and very impressed with, and with our medical director, with what they're sending out. So I would just say communicate with IAED and get the information because it's there. And I know not everybody's like that, Ted. So.
I would highly recommend that you follow Jimmy's recommendations and suggestions. I would just point out that I think Dr. Matyas kind of talked a little bit about the evolution of what has happened within our primary service answering points here in Solano County, and that was specifically that we were providing our dispatch centers with addresses initially as we began the response, but as the numbers continued to increase, that was an insurmountable goal. So now, as Dr. Matyas mentioned, our dispatchers, our call takers are inquiring as to whether there are lower respiratory issues or fever, and then advising the responders to utilize CDC precautions if they find that they may be transporting potentially infected individuals.
And Matt, I will say, just to everybody, the call screening is important because, and notifying your field chiefs, making sure they know what's going on out there, because just 2 days ago, we had a local acute or assisted living facility call us for 2 direct private medicals for flu-like symptoms. Talked to our crew, we tried to get a hold of somebody there, then they called for 2 more ambulances, and what happened was they had an influenza A outbreak inside the facility, but they didn't relay that to anybody. The medical director for the facility was supposed to come swab the patient, but didn't have time, so she told the local staff just to send them all to the hospital. So they all met our criteria. We had a soup over there. We didn't know our local hospital. It just became, it's good to have that pre-screening and make sure that everybody's communicating, and then you're going to have some rogue facilities that just aren't really working this one through, and it's going to throw people into, spiral, like what is going on here. So just a little note.
All right. Thank you guys very much. And with that, we're at the top of the hour. We don't want to hold anybody longer than we have to. Todd, do you have anything that you want to say before we wrap up?
I would just like to say thank you, very, very much. I'm sorry we couldn't get to everybody's questions. I will remind everybody of the next webinar, March 26th. That won't require registration, and we look forward to having you there. Thank you all. And Jimmy, Ted, and Doc, boy, that was really a wonderful presentation. We really appreciate your candidness.
All right, and thanks to everybody for dialing in and interneting in. Hopefully it was helpful, and look for the link here shortly. The team at FirstWatch is going to try and get it out very quickly. Stay vigilant, and wash your hands, make good choices. Thanks, everybody, and thanks for participating. And thanks, panelists. Great job. Bye-bye, everybody.
Very nice. Thanks, folks.